All right. Welcome, everyone. Thank you for being here today. We're really excited to have you here joining us for this webinar, Navigating Social Determinants of Health and How They Affect Breastfeeding. My name is Kara Kaikini. I use she, her, hers pronouns, and I'm the Executive Director of the Maine State Breastfeeding Coalition. And before we get started with the webinar, I'd like to make a few announcements. First, today is the last day of World Breastfeeding Week, and we're so glad to be able to spend it together with you. It's also the first week of National Breastfeeding Month, so be sure to check out the USBC's National Breastfeeding Month website for a list of weekly observances. And for future reference, you can find our recorded meetings on our YouTube channel. So like I said, we are recording this webinar here today. Our every other month Connecting the Dots coalition meetings are also recorded and put on our YouTube page, so you can view our recordings anytime. Also, we are happy to send you a certificate of attendance for attending this webinar if you complete the evaluation form. So that is the QR code to the evaluation form. I'll also send that to you after the webinar and ask that you send us, share your thoughts about the webinar. And if you mark that you would like to be sent a certificate of attendance, then we will do that. I also want to let you know that our next webinar, October 2nd, is going to be about functional oral evaluation of the dyad. And Angela will be speaking about functional feeding assessments, what the IBCLC's role is in those evaluations, and how to deliver individualized family-centered care. So this is one you don't want to miss. Pricing for this webinar will go back to our donation-only structure until we secure continuing education, which we hope to be very soon. We also want to remind you that our conference is coming up on Wednesday, September 17th in Augusta. And today, the last day of World Breastfeeding Week, is the last day you can get your ticket for our special rate of $100. So sign up now and use the code WBW. You can learn more about the conference at our website, mainebreastfeeds.org/conference. You'll see our agenda and information about the Augusta area, including our hotel block rate. We would love to have folks from out of Maine joining us for this conference as well. And we also offer scholarships for those of you who need a little help getting here. So just contact us at conference@mainebreastfeeds.org. And we also want to take a moment to thank our annual partners. We are a small nonprofit who operates on the generosity of our sponsors and on the generosity of our donors. If anyone who is able to donate, we're really excited to be able to offer this webinar for free in recognition of World Breastfeeding Week. But we won't shy away from still asking you to consider making a donation to allow us to continue our work throughout the year. Every drop counts. So if you can make a donation here today, please do. mainebreastfeeds.org/support. We'll put that link in the chat box, and you're also welcome to scan those QR codes if you happen to have your phone ready. For now, it is my pleasure to welcome our speaker, Dr. Tenise Hordge. Dr. Tenise Hordge, DHA, is an IBCLC and fierce maternal health advocate. Her journey into the world of clinical lactation support followed a successful first career in engineering and manufacturing, where she honed skills in problem solving and efficiency. Now, fueled by a deep passion for human lactation, she brings that same dedication to helping dyads and educating the community on the management and benefits of human milk. Dr. Hordge currently serves on the board of directors for NLCA, the National Lactation Consultant Association. Welcome, Dr. Hordge. Thank you so much for being here. I'll stop sharing my screen so you can share yours.
Thank you so much for having me. I am super excited to be here. Also, one of my fellow board members is also on the line today, Danielle, who is helping support me here today. So I just want to acknowledge her and thank her for being on this call. So thank you. Kara gave a really great overview of who I am and my background. So here's the agenda that we're going to kind of dive into today. My goal is to not only present or make some connections between the social determinants of health and how it affects breastfeeding, but also share maybe some advice or some options on how we can improve this. But before we get started, I always want to know who is most like me in the room because I want to know where my people are because it just makes me feel good and energizes me while I speak. So the little picture has disappeared of where we are. So I'm going to need you guys to send me some emojis or even comment. If I say something and it resonates with you, let me know because I have to know who is most like me. Okay? Is that good? First things first, my day 100% does not start without coffee. I am not a tea person. I don't want hot lemon water. I'm definitely not drinking apple cider vinegar. I don't care what you want me to put in it. So if you are a coffee person, let me know because I want to know who else is a coffee person.
Awesome. And Denise,
Okay.
I'm not sure if you are wanting to share your screens right
Oh,
now.
it's not sharing?
No, it's not
Well, that's
sharing.
probably why I couldn't. There we go. Let's try this again.
Perfect.
Okay. Put that in presentation mode. Thank you to all the coffee folks. No shades if you like tea, it's fine. All right, next
Thank
thing that I need to know. I grew up in Colorado. I love ice cream when it's cold outside. My husband, he is from Phoenix, and he's like, how could you eat ice cream when it's cold? It's the bomb. Like, it is the best thing ever. If you enjoy ice cream when it is cold outside, please let me know. I see you, Renee. Yes, it just tastes better. I can't explain it. Okay, one last thing before we get into it. I despise a dirty kitchen. It has to be clean before I go to bed each night. But I tell you what, if the dishes in the dishwasher needs to be unloaded, I lose all energy. It's just not my ministry. Please, somebody else unload the dishwasher so that I can move on. Am I the only one? I can't be. Great. Thank you all so much for entertaining me. Let's go ahead and get into it. You know a little bit more about me, and I know about who's in the room with me today. So that's very helpful. So I want to present something to you that I hope is not out of something that you've heard before. Breastfeeding is indeed the biological norm in which we feed our babies. However, I implore you to consider that breastfeeding is not just a choice, but rather a matter of public health. So we know that breastfeeding has lifelong benefits, right? So in the mother, we see reduction of hypertension, certain cancers, postpartum mood disorders, even osteoporosis. And when we look at the infant, we see higher IQs, reduction in juvenile diabetes, reduction in ear infections or otitis media, obesity in children, and the list goes on, right? And then we just, even with this short list of benefits, we know that access to culturally competent clinical lactation care is not readily available. And so today I want to explore these structural issues that influence these disparities that we see. So throughout the 19th century, the idea of health, it grew to not only include like the biological factors, but also these social and economic factors and how all these factors work together and impact health outcomes. There is no surprise that throughout history, those with wealth tended to have access to better medical options and thus better health outcomes. But the truth of the matter is that disease is no respecter of persons. Before we kind of dive into the social determinants of health, I thought it would be useful to understand the origins and introduce to y'all, if you're not familiar, with some early contributors. So the Industrial Revolution, it brought about significant social and health challenges. I mean, we were doing a lot of things that we'd never done before. And it really led to the emergence of something that we call social medicine, which examined the link between the societal conditions and disease and health outcomes. So just a few folks that I want to highlight here. We have Rudolf Virchow. He was a German physician who emphasized the role of social factors in disease causation, right? Because really, we never really looked at the link and how those tied together. In the 70s, out of Canada, we had the Lalonde report, and this report identified human biology, healthcare systems, environment, and lifestyles are all key links to determinants of health. So we see pockets in Europe, pockets in Canada, going back overseas to the UK. These studies, the Whitehall studies, they demonstrated a very strong correlation between social status or employment grade and health outcomes, not unlike what I just mentioned before in the previous slide. And then the second to last, the Ottawa Charter for Health, which was around the mid 80s. And this document emphasized the importance of creating supportive environments for health and also addressed social and economic factors that influence health. And then finally, the World Health Organization defined health as the state of complete physical, mental, and social well being. This was like one of the first acknowledgments of the importance of the social determinants of health and these social factors. So, all of these influences kind of culminated to what we modernly associate and accept as the social determinants of health framework. So the Office of the Assistant Secretary of Health here in the US simplified kind of this view by four pillars: social cultural, physical environment, social environment, and policy conditions. In lactation land, we tend to only focus on the mother's choice, the parent's choice. So while it is 100% a personal choice that is not insignificant, the decision to breastfeed is heavily influenced by external conditions outside of the families that we serve, outside of the realm of control. This includes racism, it includes poverty, work policy, housing, and even access to healthcare. So I pulled this image from the CDC because the CDC only 3 years ago adopted the World Health Organization's definition of the social determinants of health. And so it includes where people are born, where they grow, where they work, where they live, and age. All right. And so there's 5 domains that are represented, and I have each one of them here. Systematically, I'm going to go through each one of these and how it relates to breastfeeding. Because if we circle back, I really want you guys to think about breastfeeding as a public health issue, not just a personal choice, not just a biological function. Okay. Let's start with education access. And throughout my slides, I have included some of the latest reports and studies that I pulled here. So I can also share the bibliography to Kara and team afterwards so that you guys can all have access to all of the information that I pulled, okay? So let's dive right on in. So education, access, and quality. So studies repeatedly confirm that breastfeeding initiation and duration rates are higher when the mom or the family participates in prenatal breastfeeding education. No surprise there, right? So I'm a kid of the 80s and 90s, and I remember the after school specials. I don't know if it was ABC, CBS, the little like star that would come across the screen and little, the more you know, we know that we make more better decisions with the more information that we have, which is why we always talk about informed decision making, right? And so when we think about education access and the quality of education, the issue is twofold. So not only do we want our families, our expectant mothers, to have the prenatal education, we also have to address the quality of that education because health education is not standard. Standard messaging just does not exist. Furthermore, basic literacy, numeracy skills, even age and language proficiency, these all play a role or a part in the quality of the education that's received. So we have first generational breastfeeders. We have those who have never even seen someone else breastfeed in their family or in their social environment. We even have teen parents and those with low literacy. And these populations are among those with less health education access. Well, what can we do about it? Well, I'm glad that you guys asked. So improving educational access and health literacy around breastfeeding, it requires like a systematic multi-level approach. And it has to be culturally responsive. So I kind of brainstormed some ways that we could do that from an overall umbrella overarching look. So if we first take a look at community-based education, so we see the WIC model of that peer-led support group and thinking about how we can enhance that. Creating and providing culturally relevant education. This includes imagery because representation matters. We want to have imagery, we want to have stories, we want to have examples that reflect the lived experiences of our audience, right? We want to support families where they are. So that means going to community centers, maybe even churches or barbershops, because we know that transportation is often a barrier to health services. I did a presentation last April that really highlighted that transportation was one of the leading causes, or lack of transportation, I should say, that contributed to maternal mortality because people did not have a ride for their follow-up location. They didn't have a way to get up for their follow-up appointment with their healthcare provider. So in the year 2025, that is still one of the leading factors for us for not being able to follow up with healthcare. That's really heavy. If we look at healthcare system integration, that continuity of care, I strongly believe that lactation consultants and lactation professionals are the key to the link between the continuity of care as it relates to maternal care, because OBGYNs and midwives, they provide clinical care, even emotional support to the mother, where we have pediatricians providing that clinical support to the infant. But we, as lactation consultants, we're seeing both of that dyad. And so we're very key and crucial as it relates to that continuity of care, right? So what else could we do in healthcare systems and coordination and integration? We can train healthcare providers, improving that basic knowledge as it relates to lactation, cultural humility, challenges of the marginalized populations, and it should start prenatally or maybe even in the preconception phase, right? Policies and workplace support. So workplace breastfeeding education, maybe it's HR-led lactation education, resources, partnering with IBCLCs to provide that type of care, having information about lactation support, expanding leave, a whole host of things that we can be doing a better job of as it relates to policy and workplace support. I'm going to elaborate a little bit more on that when we get to the financial social determinants of health. Digital literacy. So one of the things that really was highlighted during COVID is the technology desert. So being able to access information or data on our phones, like without being at a public coffee shop for Wi-Fi or different things. So as a result of that, we see more digital literacy and accessibility to content. We should be able to really hop on that, developing plain language videos, infographics, maybe mobile apps with different languages that help to support breastfeeding initiation and duration. This also combats misinformation, right? Because we have information readily available, and we can combat that misinformation that leads to harmful breastfeeding myths on social media. I mean, TikTok is a double-edged sword. School and youth programs. What if breastfeeding was taught in health education and we introduced human milk as in these educational classes to normalize it? I frequently speak at my children's career day, and I talk about mammals and how mammals eat. I share the analogy of when a baby fowl is born, they start walking right away. We as humans don't do that. We're carry mammals. We have to be close to our food, our support system. So being able to have these conversations early in life, it kind of destigmatizes breastfeeding, and it sets up breastfeeding and human milk as the norm. Okay, so let's get into the next social determinant, healthcare access and quality. In 2019, only 28% of hospitals here in the US were designated as baby friendly by the World Health Organization and UNICEF. This study also indicated that baby-friendly hospitals are more likely to be state-funded than federally funded, and in areas with higher births and in competitive markets. So right off the bat, that leaves out the federal mandated like baby-friendly initiative, and it significantly leaves out smaller and rural hospitals. So this healthcare access and quality, this lack of continuity between birth and postpartum providers. Again, I think lactation providers, we could serve as a key input to improve those. And then we also have insurance disparities. We know Medicaid versus private insurance. And over the last, I would say 12 months, we have seen a significant shift in insurance coverage for lactation support and the definition of what a qualified healthcare provider is as it relates to human lactation. That is troublesome. What could we do to improve this? Well, we have processes. They're just poorly executed. I think improving healthcare access as it relates to breastfeeding, it means removing some of those systemic, logistical, and financial barriers that prevent families from receiving timely, culturally competent lactation support. So I have about 6 kind of strategies to look across. So the first Expanding the lactation workforce. The barriers to become an IBCLC are also troublesome. I think each year IBCLC puts out the number of IBCLCs per state. Yes, that information, it would be great to have it chopped and sliced in a little bit more, um, the word is more detail, it's not the word, but we have this information. If we could increase the number of IBCLCs and other lactation professionals, especially those in underrepresented areas, we would see more breastfeeding initiation or better breastfeeding initiation and duration rates. We should offer paid training to become certified lactation professionals. It's a barrier, especially if you're going through pathway 3 and having to find a mentor and pay a mentor, and maybe you still have a job. Having supervised clinical hours in community settings that build a sustainable kind of way for people to achieve that certification. Integrating lactation into primary cares, into OBGYN's office and your PCP's office, not just hospitals. Training providers to screen for lactation challenges during prenatal visits, newborn follow-ups, and well child checks. Just like we screen for the perinatal mood disorders, we could be screening for how breastfeeding is coming along, and having resources to refer to our families to. Reducing financial and insurance barriers. This requires all insurers, including Medicaid, to cover lactation support, supplies, follow-ups, without cost sharing. Simplified billing and reimbursement codes. I'm an engineer by trade. CPT codes they make my head spin. It doesn't have to be this complicated. Fully funding lactation clinics and lower resource zip codes, rural areas, all these things. Increasing points of access. Maybe it's telehealth visits. Maybe it's a mobile lactation clinic. Being able to, again, meet people where they are. Improving cultural access. So hiring multilingual lactation staff, seeking out multilingual lactation staff, and developing and providing interpersonal communication skills, English proficiency, understanding cultural differences. These are all things that are in our realm of possibility to do. Like, these are things that we can own. And then lastly, policy and system level changes. So this includes lactation support and maternal care bundles. Like, even with Medicaid expansion, we see this quite a bit with doula services, which we know that having a doula during labor and delivery significantly reduces the mother's mortality rate. Lactation is a key piece into the maternal health care system. It's just not recognized as so. And then lastly, as part of policy and systems, incentivize hospitals to meet baby-friendly USA standards to maintain breastfeeding support. That was a lot. Take a quick drink of water before we move into neighborhood and built environment. This is our third social determinant of health. So some may be familiar with the term food deserts, but unfamiliar with the term first food desert. A first food desert refers to a community or area where families lack access to the resources and support they need to initiate and sustain breastfeeding. So we typically see these areas overlap, right? And other resource deprived communities, such as a general food desert, which you're probably familiar with, or healthcare desert, transportation deserts, and even education inequality. So let me give you an example of a first food desert. And for those of you who don't know, I am located outside of Dallas, Fort Worth area. So let's consider a neighborhood in Southern Dallas, right? High population of Black and Latino families, few or no IBCLCs or CLCs or CLEs within a 20 to 30-mile radius. The closest hospital lacks baby-friendly designation, high formula marketing, low breastfeeding messaging. WIC clinics are understaffed. I know we here in Texas, several WIC clinics were closed during the pandemic and post-pandemic, and all of them didn't reopen. So that's also a barrier. Families rely on public transportation, which can make it hard to access care. I personally live in a town, we don't have public transportation. It just doesn't exist. Most mothers return to work in less than 6 weeks with no lactation accommodation. Local OBGYNs, pediatrician clinics, they don't even screen or counsel for breastfeeding. So while I read all of these things in this superficial Southern Dallas city, this could be any town USA if there is a population of low income or BIPOC families. Any town USA, your town USA. So why does this matter? First, food deserts contribute directly to lower breastfeeding rates, higher infant mortality and morbidity, increased chronic illness in mothers and the babies, and that generational cycle of poor maternal health, maternal child health. So first food deserts, it's not just about breastfeeding, it's about food justice, it's about racial and education equity, it's about maternal health access. Then we have an evaluation of unsafe housing, which can significantly impact breastfeeding initiation and duration rates. I have a really good friend who has a doula agency and house in the southeastern Dallas area, and I went to her grand opening, and there were these bedrooms that were set up for resting moms. And naivety of myself, I remember thinking, why would she have these bedrooms set up in this doula place? And it was for mothers to rest. Because I was privileged enough to have a support system and a home to go back to after I had my child in the hospital, and then I had a home birth. But I was privileged enough to live in a safe house, to have friends and family bring me food, to not feel unsafe while I was recovering from giving birth. Not everybody has that privilege, and that's why her organization exists. So once I humbled myself, I really made it my made a point to educate myself a little bit more on what that unsafe housing, lack of privacy, homelessness really looks like for our birthing families. What we see tacked onto that is chronic stress. We know that cortisone, that chronic stress, can impact not only milk production, but also the ability to start or sustain breastfeeding, right? And then if we further look into what these unsafe or unstable housing conditions look like, not feeling comfortable breastfeeding, it can look like violence, it can look like poor sanitation, it can look like overcrowding, all adding to stress, right? And so we know that this stress can undermine a parent's confidence, their patience, and the capacity to bond with baby. Research shows maternal stress is strongly linked to early weaning. And yesterday I spoke about the complexities of human lactation and supply and demand, and had a whole section on how cortisol really can mess up with breastfeeding initiation and duration. Lack of privacy, safe feeding spaces, if we're in shared rooms, even if it's within family, and we have a generation who doesn't believe in breastfeeding, or who's constantly asking, the nursing parent, why don't you just give the baby formula? We have environmental hazards, mold, pollutants, pests, all these things, lead. We're still in a place where these are all active environmental hazards within the families that we serve. And then lastly, reduced access to in-home lactation, or being able to travel to get lactation support. So without reliable transportation, families may miss their appointments for critical breastfeeding help. I know I've had that happen to me in my private practice, and have luckily been able to offer virtuals. So these circumstances, they perpetuate the cycle of poverty and undermine that health autonomy. So it's not a lack of desire for our families to want to breastfeed, it's the lack of systemic support. So what can we do about this? Well, again, I'm glad that you asked. We can increase access to local breastfeeding support. And this is twofold, right? So it's coming to where folks are. It's lactation in the workforce, providing training programs. It's being in walkable distances, but it's also increasing the number of clinical lactation care providers. And what that looks like, it provides jobs, it provides trust, because we know that convenience and trust in the location can be the difference between getting help for breastfeeding and not. We can create breastfeeding supportive public spaces. This looks like lactation rooms, quiet feeding areas in the mall, parks, government. I see pockets of that. I see, some airports, even some parks that do a really good job of that, but we could do better. Why this matters? The physical environment either supports or undermines a parent's ability to breastfeed comfortably. Engaging with local businesses, because we want to normalize breastfeeding, right? So we're training neighborhood businesses to be breastfeeding welcome here. And that could be salons, grocery stores, coffee shops. Why that matters? Local businesses, they shape daily life. Normalizing breastfeeding in those spaces, it makes it part of the community culture. Addressing transportation and infrastructure gaps. So again, this is maybe ride shares in these deserts that I talked about. Maybe it's a mobile lactation clinic, and maybe it's having clinics that are walkable or easily accessible, because physical access to support is often limited by a neighborhood's layout or infrastructure or lack thereof. Making hospitals baby friendly. We already have the playbook. We just have to do it. That 2019 study of only 29%, that was disheartening to read. We can require prenatal and postpartum breastfeeding education in all Medicaid funded clinics. We can fund baby friendly certification in safety net hospitals. We can encourage skin to skin, rooming in, and then promoting economic and workplace equity. Create jobs. We can create lactation jobs. We can expand family leave or even establish. We can enforce the PUMP Act. We can provide stipends for breastfeeding support during postpartum care. Let's move on to the fourth social determinant of health, social and community context. There are significant social and community barriers that affect health outcome as a whole, not just breastfeeding. Some noteworthy examples include the forced sterilization from the HIS, or the Indian Health Service, of Navajo women, Puerto Rican women between the 1930s and the 1970s, or even the Tuskegee experiment. The effects of these atrocities continue to cause cultural stigma and a lack of social support. They influence family history, and quite frankly, they create generational trauma. If breastfeeding is discouraged by a partner, a family, a faith group, or a mom has some trauma that she's carrying around as it relates to breastfeeding, it can derail her goals before she even starts. These outcomes, they equate to health disparities, reduced participation in research studies, racial and ethical biases, and undermine the treatment of pain and can cause general skepticism. This is super heavy. What can we do about this? Well, we can improve breastfeeding outcomes through social and community efforts in a way that supports our families. It makes them informed, and it helps them to feel empowered in their environment, right? And so we're working to normalize breastfeeding. We're also making sure that we are working within the communities, like grassroots campaigns, friendly campaigns, including signages, promoting what it looks like to breastfeed, having examples of the populations that we serve so they see themselves in those images. Encouraging public breastfeeding through local ordinances, breastfeeding welcome here programs, kind of like what I talked about on the previous slides, partnering with our small businesses. Leveraging peer and social support, training lactation professionals, removing the barriers to become an IBCLC, creating jobs in doing so, providing lactation support during other community service activities, such as food pantry pickups or school meetings. Well, why that matters? Families are more likely to engage in breastfeeding and breastfeeding education if it's woven already into their existing relationships and routines. Again, it's normalized. So another way we can do this, addressing stigmas, myths, cultural misunderstandings. I'm guilty of it too. I see some stuff on social media and I'm just like, not today. And it's just because I'm really not a social media person and I'm working on it. But we have to address these stigmas. We have to address, misinformation, incorrect information, because that's how we're going to learn, and that's how we're going to raise the bar in lactation care and understanding, step by step, if not for us, for at least the next generation. This can look like creating culturally grounded education materials, really addressing those stigmas with misinformation, with data, so that people aren't sabotaging their breastfeeding journey before it even starts. Educating families early on, very similar to my previous slide about health education in high schools and health classes and parenting programs and prenatal workshops, and encouraging that multi-generational learning, like bring your abuela, bring your grandmother, bring your auntie, like bring them to these conversations so that we can include this multi-generational learning. Why it matters? Early and inclusive educational, it shifts the generation norms and expectations, right? Centering equity and inclusion, supporting BIPOC, immigrant-led breastfeeding programs, low income, compensating community leaders for their parents for their time when helping with outreach or programming. I'm gonna say that again. Compensate community leaders and parents for their time when helping with outreach or programming. It doesn't always have to be a volunteer basis. I mean, I think that's really great to be able to do, but we should also really look into how ways that we can compensate people, especially for their time and their energy. So why this matters, sustainable outcomes happen when community members are empowered, not just served. I want to bring people along with the process. Moving on to economic stability. As a reminder, the US is the only industrialized nation without federally enforced paid maternity leave. That reality alone pushes people to stop breastfeeding early. Even when parents want to breastfeed, survival often comes first, but having enough money. So this has a significant impact on economic stability. Lack of paid maternity leave and returning to work too early, or the cost of lactation support and supplies. And we're seeing this a lot as we've seen some insurers choose not to reimburse lactation visits or limit the number of lactation visits. So an example of this is parents choosing formula due to inflexible jobs or lost wages or threat of lost wages. What happens when the baby who has only been fed at the breast does not take a bottle, right? And you go back to work in 3 days. So it complicates things. Mom's maternity leave is over. She has to go back to work. Baby won't take a bottle. Insurance only covers 6 visits, and 3 of those visits may have been used up prenatally with breastfeeding education. Or those 6 visits are now split by visit codes, and it's really only 3 visits versus 6. These are the type of issues that our families are faced with, and that we as lactation consultants and the lactation professionals are trying to navigate against. So what could we do? What could improvement look like? Well, we could expand paid family leave, advocating for universal paid parental leave, especially in low wage or hourly employees, right? Ensuring that job protection during leave to prevent retaliation or job loss. Even the weird comments, oh, you're still feeding, you're still breastfeeding, you have to go pump. I mean, I got those in my corporate career. Why it matters, paid leave improves breastfeeding initiation and duration and gives parents time to establish milk. Not to even mention that it takes about 10 months to grow an entire human. And then we're expected to quote unquote bounce back. And your body is still recovering and healing from a whole process. Okay, enforcing workplace lactation protection, so guaranteed break time, private spaces for milk expression, especially for our hourly or service workers. Training employers on legal requirements, the PUMPT Act, economic benefits, supporting breastfeeding employees, understanding that increased morale comes along with supporting parents during this postpartum period. Many mothers will stop breastfeeding early because their jobs didn't support pumping. Providing economic support for breastfeeding families, maybe that looks like subsidized breast pumps or milk storage supplies or nursing bras, for low-income families. Maybe that looks like supporting housing stability, food security, transportation access, so that we can make sure that people are getting to their follow-up or their very first initial visit. Why this matters, financial insecurity increases stress and it decreases access to helpful tools that support breastfeeding. We can fund lactation support as a public health priority. Ding, ding, ding. Lactation services, it's a social safety net programs such as Medicaid or SNAP or child welfare interventions. Having peer-led programs that employ and compensate community lactation workers. The volunteerism is something that we really need to reconsider. When lactation care is inaccessible, formula becomes a default. It's readily available, not because families want it, because it's what they can access quickly. It's what's right there. We can build career and business opportunities in lactation. If you haven't picked up from me, I love what I do. I love supporting families. I love human lactation. Human milk is fascinating to me. And while everyone else might not feel that way, we can certainly create programs that build career and business opportunities for those interested in the work and who really love this work. So creating economic mobility by funding pathways for BIPOC low-income individuals to become a lactation professional and or IBCLCs, to achieve an IBCLC, supporting breastfeeding-centered social enterprises, milk banks, nursing apparel lines, mobile lactation services. Why this matters is empowering families to both give and receive support helps break those generational cycles of economic instability and poor health outcomes, because breastfeeding is a matter of public health. So what could this look like? Just finish that. Okay, so it's very complex interactions. I mean, that was a lot. The intersection of social determinants of health and breastfeeding create a very complex web of history, concerns, and even opportunity. There were several reoccurring themes there, right? Access to qualified providers, lack of leave, limited education, even lack of transportation. So we can't solve the social determinants of health overnight, but we can take action. At every level of care, policy, we can build systems that help breastfeeding thrive. That could look like screening for the social determinants of health in lactation and pediatric visits. It can look like partnering with grassroots community organizations. It can mean training staff on biases, trauma, and equity. And it could be advocating for paid leave and insurance reimbursement. Community-based programming has been one of the most successful initiatives in improving health outcomes. We have many examples of grassroots community organizations being instrumental in improving health outcomes. So one of those was COVID-19. So we saw effecting change to contain and reduce the spread of COVID-19. We saw the campaign for tobacco-free kids in the mid-90s that really protected children from seeing smoking on billboards and even TV shows and commercials. Grassroots efforts played an absolutely critical role in the fight against AIDS and significantly influenced the course of that epidemic by filling that void in government inaction and stigma. In the early days of the AIDS epidemic, the government often reacted with neglect and misinformation, and people living with HIV/AIDS, they faced widespread stigma and discrimination. It was the grassroots efforts that really made a difference in all three of these that are captured here. Okay. So if we expand community-based lactation access, we can address many of the social determinants of health: education, access, quality, social and community. How this works: beyond training local mothers with breastfeeding experience, we can create jobs. We can also include affordable pathways to become clinically lactation professionals, offer prenatal visits, hospital follow-ups, partnering with OBGYN, other healthcare providers, PCPs. The impact of this increases breastfeeding initiation and duration rates, and it builds cultural language congruency, especially in BIPOC and other underserved communities. Culturally rooting breastfeeding coalitions, right? So this really looks like coalitions that are formed and are targeted for specific populations. This provides that culturally safe support group. This looks like lactation consultants, doula services, workshops to families. Again, this is building trust in healthcare systems through culturally competent care. It normalizes breastfeeding in communities when often places it's discouraged. Home visiting programs. This is one of my initiatives that I'm currently working on. So we have nurse family partnerships, healthy starts. These individuals, they already have a relationship with families. They're trained professionals visiting families either while they're pregnant, preconception, postpartum, offering education on breastfeeding, parenting, nutrition, navigating healthcare. This is a great underutilized resource in helping with the initiation and sustainability of breastfeeding. This no judgmental care, it improves access because there's already a relationship that's built there. Having breastfeeding friendly workplaces, employer engagement initiatives, this is all addressing economic stability, neighborhood built environments, and it really educates and supports employers on establishing those breastfeeding accommodations. Okay. Lack of equity and fellowships and community IBCLC pipeline programs to address that. We should fund the training. There should be a mentorship. Again, we don't want to ask these people to do this for free. There should be ways that people can achieve their clinical hours, especially in underserved communities that really need access to this type of support. And then mobile lactation clinics, again, meeting people where they are, drop-in centers, partnering with community centers, providing free or low-cost lactation support in convenient neighborhood locations, because our insurance is not kicking in here, right? Because we don't have access to these things. So how could we better support access to families who don't have the out-of-pocket, but also supporting a livable wage for our clinicians? Breast pump access, supply drives, again, economic stability, healthcare access, partnering with nonprofits or other healthcare departments and the grassroots community-based organizations to improve access to supplies, access to care. Maybe that's working with NICU parents. Maybe it's providing pumps for back to work, right? So there are several programs that already do a really great job of this. We have mobile clinics, we have Black Mamas Breastfeeding, we have Rose, we have breast pumps for every mom, we have CAPA certified lactation educator training. So there are some pockets of some organizations that do this really well. I think the key is honoring the lived experiences and community wisdom that we can share and kind of capitalize on, addressing multiple social determinants of health at once, leveraging trusted messengers like doulas, like peer counselors, like community health workers, like home visitors, and building sustainability through policy integration and local partnerships. That was a lot. I ask you to reflect in the work that you do. What barriers do you see in the community you serve? Just one, and one way that you can address it. Is there something that I said today that sparked something within you to address one of the barriers you see to clinical lactation support? You certainly don't have to share, but if you'd like to drop that in the chat box, I would love to take a look at that. So final tips and resources. These are just a few resources that I recommend for further learning and action. Please explore them. You can take a screenshot of this, share them, and use them to be more informed in the work that we all do. Thank you so much for your time. I know that Kara has a couple things to add, but I'm happy to take a few questions if we have time.
Yeah, absolutely. This was really, really great. As I mentioned in the chat, like you're speaking our language. This is the stuff we talk about and think about all the time in the Maine State Breastfeeding Coalition and on our board. And the last 9+ months, we've been working on our next strategic plan, which includes a lot of what you mentioned. So that made me feel like, okay, we're really
All right.
considering a lot of these things, but there's so much, as you just shared in the last 45 minutes, there's so much that we can be doing. And there's so many barriers that are really, really important to be aware of. So I really appreciate the time that you spent going over that with us. And I think you mentioned you might share the slides so that folks
Yes.
can look through those again as well. Awesome. I see Larissa's comment that the pathway to becoming an IBCLC is incredibly daunting. And
It's not easy. We don't make it easy.
no, I agree. Yeah, and if there are any other thoughts on that or that's one big piece of our strategic plan is going to be on increasing access to lactation support, right? So that can be so many different things, but expanding the workforce in particular. And I think a lot about how we can do that, especially when it is challenging to become an IBCLC. CLCs are also amazing. That's the other most common credential that we see in Maine. And so there's room for all of it, right? And the work pair counselors are amazing as well. So
Every
yeah.
yeah, everybody has a needed place in lactation land, right? Every credential is needed, and the reality is there's not enough. Even with all of us, there's not enough. For an example, in the county that I live in and work, there were, I think, 33,000 live births last year. There's not 33,000 IBCLCs in the state of Texas. There's like 1,200. Imagine if everybody in that one county needed support.
Yeah, exactly. And so it needs to be an enticing career too for people to go into. And as someone mentioned, like a lot of roles require the IBCLC to be an RN. And in some situations that makes sense, and others it might not be necessary. And we're really excited in the state of Maine to have just passed a bill that requires Medicaid reimbursement for private practice lactation consultants. So we're hoping that that will help lactation consultants who want to work in the community, and not necessarily in the hospital where they should already be getting Medicaid reimbursement, hopefully. But for the community support to be expanding, hopefully that will make it a little more. But the private insurance is also a challenge for a lot of folks. And if
Absolutely.
you know someone in private practice, that is a big bear, I guess you could say.
Absolutely. And I touched on that a little bit without naming names. So if there's any private practice folks on the line, I'm sure they can connect the dots.
Yeah, yeah. Awesome. What questions do folks have? I'd say let's take advantage of this time with Dr. Hordge, a very knowledgeable expert on this topic. Or are there any other thoughts that I see Bree has a comment. I'm a public health nurse who does lactation support home visits, but because of costs, I don't have a scale accurate enough to do weighted feeds. Yeah, it's expensive to be a lactation consultant, and there are a few things that you need, like an accurate scale. I'm sorry to hear that as a public health nurse, that's not an expense that's being covered for you. Feels like that's something that would be important. What other questions or comments? Um, I mean, I think understanding the whole concept of the first food desert is really important too. I'm really glad that you talked about that because, we hear about maternal healthcare deserts as well. And that is something that we're seeing in the state of Maine too. A lot of birthing hospital closures, and it's we have a lot of people in a good percentage of our state who live really far from most things. So we are talking a little bit about mobile health too, and what are some options there. I'm curious if anyone, I've posted this in a USBC um, email list as well, but didn't see a lot of responses. But what kind of telehealth resources are out there that you are all aware of that might be either in your state or open to other states as well? At one point, there was the Office of Women's Health had a hotline, but I
Mm.
called it a few months ago and it was not something that I was going to want to recommend to folks. It wasn't quite what I thought it was. But if anyone knows of any, I know that a number of private practice lactation consultants offer their own telehealth, but I'm wondering if that's something that could be spread more widely, the availability of telehealth options. It's not always appropriate for lactation consults, depending on the situation, of course, but I'd be interested to hear what's out there. Um, yeah, and going to high schools and doing lactation health education. Great question. If there's a curriculum already out there, I would love to know that too.
Not
Oklahoma.
that I'm aware of. I know that I've developed some things for not at the high school level, but at the elementary level. But that'd be a great resource. Yeah.
Yeah. Haley, thanks for sharing that Oklahoma has a hotline. That's great. I may have come across that. That may have been shared actually, but I'm gonna definitely check that out. Awesome. Other questions or thoughts? While everyone's thinking or typing, I will put in the chat too about our conference. I mentioned I was going to put that and link in there. And then I'll also put a link to the um, evaluation as well so that folks can have that handy and it will be emailed out. I see Danielle's comment. Love to add breastfeeding information to sex education beginning in kindergarten. Yeah, as this is the way many babies are fed. And a curriculum in New York from the 90s. That would be interesting to see. Yeah, Susan, thanks for sharing that. The UMass Boston has a free virtual class for prenatal and breastfeeding moms every Wednesday. Yeah, I used to run a virtual group through Maine Medical Center, and it's a link that anyone could join. And I'm wondering how many people you often have in that class. It's great to know if there's a link that you can share for folks if people are looking for a virtual prenatal class to share. That would be great to have that link. Yeah, it's interesting. Okay, that's what I was wondering. It's like there's such opportunity for there to be um, so many people joining since it's available for anyone anywhere to join. But it's not as enticing sometimes, I guess, as being in person. And totally understand that. Danielle, I'd love to see the lesson plan you created for high school kids, if that's anything you'd be willing to share. I'd love to see that. Yeah, I will put that in. If anyone has any questions. And Dr. Hordge, would you mind putting your contact info too for anyone who has any questions for you?
Sure.
Yeah, the Leche League also is a great resource. I know that it's probably more common in some areas than others, but that's always good to look up. I'm hopeful that the directory for the Leche League USA, I'm guessing they must have a list of the Leche League groups throughout the country. Mhm. All right. Well, thank you again, Dr. Hordge, so much for coming today and sharing your knowledge and wisdom on this really important topic of social determinants of health and its impact on lactation and breastfeeding. We have your contact info if anyone has any questions, and I really look forward to connecting with you more in the future. And have a
Thank
great
you so
day.
much. Thank you for the opportunity. Thank you, everyone.
Bye.